you are consenting to the recording. We will share this recording with everyone on Thursday, so everyone who registers will get a email and some links to all the CBCs, including today's. We'll also share any juicy information that comes up in the chat, so we'll make sure we capture all that. Speaking of the chat, please use that promiscuously. Ask questions, leave comments. We'll be monitoring that, but we also would love to hear you and see your beautiful face. So if you want to join in the conversation, make a comment, ask a question, you can raise your hand, and our wonderful moderator, Annette, who is a colleague of mine on the Scientific Planning Committee, we will call on you and have you go on video and ask your question live. So without further ado, and since time is short and soon we'll be getting on our roller skates to head over to CROI, I am going to turn this over to our moderator, Annette, who will introduce herself and bring on our speakers. Thanks again so much for being here.
Hi, everyone. I'm Annette Sohn from AMFAR's Treat Asia program in Bangkok, Thailand. I'm also voluntary faculty at UCSF in the Department of Pediatrics, and really honored to be here today to help moderate today's CBC. And our two speakers are Allison and Judy, so I'm going to ask them each to introduce themselves. So Allison, please go ahead.
Sure. Good morning, everybody. Allison Agu from Johns Hopkins in Baltimore, where I'm a professor of adult and pediatric infectious diseases. I also am relevant to this, I'm the chair of the HIV Medicine Association in the US. So really excited to be here. It's early, but later for me being on the East Coast, so really excited to be part of the conversation.
Thanks, Allison. And Judy?
Hi, I'm Judy Currier. I'm at UCLA, a member of the program committee for CROI. I'm an adult infectious disease doctor, an HIV provider at UCLA, and I'm also chair of the AIDS Clinical Trials Group. And I'm also thrilled to be here and so impressed at everyone getting up so early. Thanks for the music, Jim. Got us all moving a little bit here before we start.
Okay, thank you, Judy. And a brief shout out to my colleagues and friends in the Asia Pacific. I see you, and I know it's really late, so thank you for joining. So for today's format, each of our speakers are going to speak for about 10 minutes, and then after each talk, we will go ahead and take questions from the chat as well as people who have raised their hands directly after that. We'll do our best to include all of them and then move on to the next speaker. So we're going to try to balance out the time because it would be great for us to have a joint discussion between Allison and Judy and not just for one or the other. So we'll try to do that. And again, we'll do the best we can. And if we can't answer your question live, we'll try to do it in the chat itself. So first of all, I'll turn it over to you, Allison.
Yeah, so I think doing this morning, it made me really focus. Sometimes you can be super distracted at the conference and all the hugs you give. I think excited to really be talking about how complicated it is. I think someone in the chat introducing themselves saying they're a lifetime thriver. I love that flip of it, and not surviving, but thriving, and then claiming the name and being a thriver. I think there's been a lot relevant to the surviving lifetime with HIV at the conference. I selfishly want to point out the session yesterday that if you were not in the room, that you need to virtually go back and be in the room, which was a session about essentially living into young adulthood with HIV, which was a focus on people born with HIV or the dandelions of the lifetime survivors. And I want to spend most of my time, not about half of my time, talking about it there, because it was really so well flavored in the sense that Annette, you, Jennifer, Zhao, and Elaine really put together a session that was co-moderated by Victor Reyes. I don't know if Victor is on the call this morning, who is a lifetime thriver born with HIV, but it was flavored with not just the epi. And I think where I sit in the US lens, we oftentimes talk about the 12,000, 10 to 12,000 young people who are born with HIV who are going into adulthood and how that is aging. And we're seeing them in our clinics and making sure that we spotlight them. But Dr. Mutsa Sabisi pointed out that actually worldwide by 2047, there'd be 2 million people who have been born with HIV who will be adults at that time. And it makes, I think, the call to action different, right? Not that 12,000 don't matter. 12,000 is really important and a big number that we focus on. 2 million, and we're looking at what's going to happen to those 2 million individuals over time. And then Ezra Kang gave probably one of the most impactful talks that I've seen about really the mental health and well-being of lifetime thrivers, and talked about how they reflect the epidemic and what it's meant to their psyche. And Victor, co-signed and said, yeah, actually, he spoke to exactly what it meant, moving from coping to thriving, from innocence to culpability. Really, if you didn't see this talk, please go back and look at it. And then last but not least was Sarah DiMargio Fargo talking about the cardiometabolic complications to anticipate for lifetime thrivers, right? I've already coined it or stolen it, and how and what that would mean. So I think, again, a lot of times if you've heard me talk, you've heard me say that there's a LifeLock commercial where there's people that's in a bank, and there's a bank is being robbed, and there's what appears to be a security guard standing there. And they're like, do something, the bank is being robbed. And he's like, I'm a security monitor, I'm not a security guard, right? So the bank is being robbed. And I feel like a lot, we've been talking about the bank being robbed. And in looking at the talks and what's been being presented, there's a bit more about not just understanding what's happening with inflammation and with, markers of what's happening, but then what to do with it in a way that feels actually reachable. So yeah, things are under embargo, so I know the reprieve stuff is going to happen Wednesday in terms of the big session, but people may or may not know that there have been a huge study of 5,000 people on a pivastatin, which is a cholesterol lowering medication, which was given to people who wouldn't quite qualify to be on cholesterol lowering medications, and showing that essentially there was a decrease in hard outcomes, right? So heart attacks, strokes, things that actually we know, or NCDs, or non-communicable diseases that can impact people with HIV. And that led to a change in the US guidelines in terms of the Department of Health and Human Services recommending statins for people with HIV to improve survival. So again, not just monitoring, but now doing something. I would be remiss if I didn't say that study did not include anybody below the age of 40. So while we're talking about lifetime thrivers and saying, hey, we know they're going to have things that are going to happen to them, we do need to untangle this question of, well, should they be on statins earlier? And I think we're going to be talking about that. I know some are starting to do that, but I think there is an argument to say that 35 or 40 years born and living with HIV is probably the same as, and if not worse, than being a 65-year-old, 40 years of HIV. So I think that conversation is one that I would love to have, and I think push for us to really think about how to decide who may be the best people to do that, to benefit from that. In that range, I don't want to steal your thunder, Judy, because I know you're going to highlight the whole session on weight change and semaglutide. So I'll leave that for you to talk about. But I think exciting to see that semaglutide does impact weight change, so decrease in weight, and it's a diabetes drug, I should say, or a glucose management drug, does decrease weight, but also decreases inflammation. So again, not just seeing something, but what can we do? There was another talk, so thinking about the heart, thinking about inflammation. There was a session on the brain yesterday, and I think I spent a lot of time thinking about how do we make sure that people are living their best, and having a mom who has Alzheimer's and watching what happens to the brain and how it robs people. How do we, for people who are living lifetime with HIV, how do we think about how to best protect their brains, and what are the things that we can do? Again, not just monitoring, but potentially implement or intervene. And the session yesterday, there was one talk that I thought was really interesting, because it was depression and stroke. And looking at the impact of depression, we're all doing these PHQ-9s and monitoring depression in our patients. And our mental health system is variable, right, in terms of how well we actually address depression. But this study, a small study nonetheless, but showed a connection between depression scores, moderate to severe depression scores, and the incidence of stroke after controlling for all the other things. And that association was highest in those who were under the age of 50. And didn't say perinatal or not, but under the age of 50. So should we be doing better? I think these things are all highlights for me of calls to action. And maybe we should see something, say something, do something, and there may be more that can be done. And some of this may be low-hanging fruit that we can address, diet, exercise, addressing people's depression, counseling, et cetera. So I think a lot of really exciting, for me, things, and I love to hear what people's thoughts are as well about that. So really looking forward to the interactive section on, again, the cardiovascular things, more on brain coming up in the next few days. And the plenaries, I should say, really I think, amazing plenaries about what could be coming, whether it's BNABs or other pieces that may be coming down the line, and how they impact people across the spectrum, pre getting HIV to maximizing life with HIV. So with that, I'll stop and turn it over to Judy.
Well, thanks, Allison. Actually, we're going to go ahead and take a few questions and comments now so that, people have these things in their minds, and then we'll move over to Judy. So the first thing I want to raise is, Nina, I don't know if you wanted to raise your hand. So anybody who wants to raise your hand, you can. But we had a comment about there's a difference between lifetime surviving and lifetime thriving. And so why don't we ask Allison to reflect on that? But anybody who wants to, just please raise your Zoom hand or note something in the chat, and then we'll go ahead and refer to you.
Yeah, I'm blanking on the investigator or the paper, but there's a really neat paper, I think it was in JAMA a couple of years ago, that looked at the difference between individuals who are living with HIV versus those who are not, and the difference between lifetime and then lifetime with or without comorbidities. And so while we've made lots of strides in terms of improving people's survival, the years of comorbidity-free survival are actually less. We have, people living with HIV have fewer years. They're basically living longer, but those years are filled with more comorbidities. And so to me, thriving means that we maximize life and we've minimized the amount of that time you're dealing with the comorbidities that impact your life.
Okay, thanks. And another point that Daniel raised, although it's also kind of getting to Judy's point, but I want, since you brought it up, Allison, maybe we could address that, is that, adding a pill to your regimen, especially thinking about the complexities of where people may have recently changed their regimens to different drugs or potentially a new injectable, things kind of get complicated, as Jim said at the beginning. And so what are your thoughts about that? I mean, there are data that show it could be beneficial, but that's not the only thing we're thinking about here, right?
Yes, so I completely, I completely agree. I mean, I think certainly I have a US lens, and if there's a pill, we want to put it on board, right? So, we focus on, we pay for this pill to those pills. I think you're absolutely right. And certainly it's harder to do studies of, what if you write somebody a prescription for healthy meals that they can get for whatever? How does that impact? We actually cover things like that, right? So I think it is about optimizing the options available to improve survival. Now, if a pill is not for you, what else do we need to be thinking about to be able to help you get to that thriving without adding a pill? And so is it that you do injectables in a pill? Is it that we cover other things like therapy for people in a meaningful way that can get you there? So the point is absolutely well taken, because adherence is challenging, and one more pill can just be literally the proverbial straw that breaks the camel's back. So very good point.
Okay, thanks. And when we have a question from Lou, and I hope my Google Translate is accurate, but from the French, it looks like, what are the provisions for people who are elderly in prison in terms of treatment? And maybe, I know that it's a different context from country to country, but can you comment on at least the US context, or whether these kinds of new treatments are being made available to people in prisons?
That's a really good question. I do not take care of individuals primarily in that context, though, but I certainly know HIV treatment access is available. If we put them in our guidelines, right? So, which I think is really critical. You put in the guidelines, I think the prison healthcare system, and I will defer to anybody who is actually in there. If you put in the guidelines, then we have to follow those guidelines in terms of getting people on those appropriate treatments. But I will happy to take, comments from others who may know more or practice it in that context.
Ah, okay. It looks like maybe there was a typo, or my Google Translate was wrong. So I'm sorry about that. But it does sound like, what are the current provisions for elderly people on treatment with regards to maybe the statins you were talking about? And this has come up a few times now, and questions for both Judy and Allison. So maybe, since no one's raised their hand, I think maybe we'll ask Judy to comment, and then we'll have both of you answer some of these questions that get at, as someone said, you're surviving for 10, 20, 30, 40 years living with HIV, and that this is a common challenge for people in that group. And so separating it by whether you were born with HIV versus not born with HIV, there are certainly some differences that Allison, you mentioned, but then there are a lot of similarities. So maybe we'll go ahead, and people, please keep putting questions in the chat, but we'll turn it over to Judy to raise some of those points that Allison was alluding to. Judy?
All right, thank you, Annette. Thank you, Allison. Yeah, so I think it is complicated, but I think what this conference helps us see is that we are getting new data to address many of these different issues. And so, I wanted to talk about a few things that have been presented and highlight some things that are coming up that are embargoed, but I want you to go and see, because I think there's a lot of important things on the horizon. And just going back to the plenary yesterday from Nellie Mugo about cervical cancer, she reminded us about the importance of cervical cancer worldwide, being the fourth most common cancer in women, and for women living with HIV, higher rates of having HPV, the virus that's associated with cancer, higher persistence of the virus. And this is a disease for which we now have a vaccine that is so effective. And I think if you're thinking about across the lifespan, anything that we can do to facilitate vaccination of young women, screening for cervical cancer, and improving treatment is so worthwhile. And it was such a juxtaposition between the talk about the HIV vaccine and then the talk about a vaccine that's here, that we have now, that prevents cancer, prevents cervical cancer, and we still can't figure out how to get it to people who can benefit from it the most. So the challenges of implementation of our discoveries and findings just need to move so much faster than they have. And I think the work that's been done has been incredible, but it's about really having the political will and the resources to make this a priority. So cervical cancer is a really important topic, and I thought it was a phenomenal plenary. And if you didn't get a chance to hear it, I'd put it on your list of recordings to listen to. I think that, as we think about aging with HIV, there are a lot of different challenges that we face as we age and that people living with HIV face, and it has to kind of be personalized. What are the issues that are most important to you, and maybe the challenges that you have a higher chance of encountering, and making your own personal plan about what you can do. And I think at this meeting, we are hearing a lot about cardiovascular disease as one of those things. We're hearing and learning about weight gain as another. And I'll talk about those a little bit. But we're also hearing about HIV treatment, maybe for the first time in a while. It's a lot of new data on new drugs and new strategies in development. And that also has to continue to be at the core of how we optimize living healthy over a long period of time, is that we are getting some new regimens coming along. We heard yesterday about new once a week oral regimens. Injectables have been approved, have not been widely made available yet. And I think there's some really great things about the current cabotegravir and rilpivirine, but it's not for everyone. It's not for people who have hepatitis B, and it's not for people who've had resistance to the NNRTIs, but there are other things coming along, and I think that's really encouraging. We're trying to figure out what's the role of the broadly neutralizing antibodies, long-acting, in treatment, and so we heard more about that yesterday, which I think was good. And then lenacapavir combined with broadly neutralizing antibodies as a potentially 6-month regimen. So these things are still in the early days of being fully developed, but I think there's hope that drug development for HIV is not stopped, and that we are continuing to look for new ways to make treatment easier, and to have more options. As Allison was saying, it's about choice and what's going to work best for individuals. And then we heard the really exciting I thought study about long-acting cabotegravir and milpivirine in the African context from Sissy Kicho was supposed to be doing the presentation from Uganda, but was unable to get her visa. And so Nick Patton gave the presentation. And that study, demonstrated with the more of a public health approach that for people who are suppressed on treatment with TLD, tenofovir, lamivudine, and TDF, that they could switch to this if they didn't have hepatitis B. And that was a big thing in the study, that they screened 1,000 people, but almost 400 couldn't be enrolled because they had measures of hepatitis B. But for those who did enroll, they did just as well. 96%, 97% remained suppressed, and they only checked the viral load once every 6 months. So that was really great to see some progress in that regard. So I just wanted to just make a few points about HIV treatment, because that was already presented and I could talk about it. But, and I think that the studies with injectables have shown that for people who choose to enroll in them, and that's very important because they aren't for everyone, but for those who choose to enroll in these studies, they do report that they have a high, they feel better, higher quality of life. But not everybody chooses to do this because they aren't for everyone. And I think that's the point that Jeff has also just made in the chat. So in terms of other topics, I think one thing that we don't talk enough about and pay attention to enough about as a health-related behavior, and that's our sleep. Sleep is becoming, really appreciated, as this could be one of the factors that contributes to so many chronic diseases for people who are unable to sleep well during the night and rest. May contribute to inflammation, depression, weight gain. So understanding what are the factors that influence sleep disturbance in people with HIV is a really interesting topic. And there was just one poster about sleep apnea, which is a condition where you wake up during the night because you stop breathing, sort of. And that was not more common in these clinics in the Kaiser system in people with HIV. But there were people who had HIV that was not well controlled, maybe had a little bit more frequently. But I just think seeing more stuff about sleep was good, and I hope that continues. And then finally, the cardiovascular disease, there's a lot at this meeting, and there's a lot today. So the session at 10 o'clock about complications, I encourage you to go to, because it includes great presentations about risk factors for heart disease, but also for weight gain, and particularly among women. So I think that's an important presentation. And the posters today is some more data from Reprieve about how good are we at predicting an individual's risk for cardiovascular disease. We use these equations that you put in your age and different parameters, and it says what your 10-year risk is. It turns out that these may not perform as well for people with HIV, and particularly for women. So we're going to learn more about that today. And I think that's going to be an important topic moving forward. And then finally, getting back to the statin issue, as Allison said, the Reprieve study did demonstrate this benefit in reduction of cardiovascular disease, and that the population that was enrolled were people over the age of 40. It did not have a strong representation of transgender men or women. And so I think that somebody did raise this in the chat. It's very important that we focus on what the hormonal effects are in terms of cardiovascular risk. But the guidelines did, suggest shared decision-making with your provider about whether this is an intervention that it could be beneficial to you. And I think it's a personal choice. And I think it's just something, and it was nice to see somebody mentioned their provider just brought it up this week. So their provider's on it and thinking about it. And I do think, for people who've decided to make the switch to injectables, finally gotten off taking pills, this thought of now you have to take another pill is something that, you need to work through. But it's a decision based on your understanding of your personal risk. But I think it's good to have this data. So as Allison said, people have more choices and can make more informed decisions about what interventions they want to do to try to have healthy aging with HIV. So I popped around with a bunch of different topics, but I do feel like I'm very hopeful from this meeting that we are getting more data to help so people can make decisions and have choices.
Thanks so much, Judy. And I think you've addressed some of the questions and comments in the chat about statins and the reprieve. I mean, it is everywhere. And those of you who are not at the conference, there's gonna be a lot in the media. And so this question of, well, is it really for me? And you brought up the importance of shared decision-making. And we've had some comments in the chat about that. The data are not there for cis and trans women. And what does that mean for, and Allison, as you brought up, for young adults? And so and then there were questions about vitamin D supplementation and other pills and just adding to the burden of these data. As you said, the trials are there, as was mentioned by Nina in the chat. These individuals make up these trials, but these trials are not everybody. They're a representative sample. So Allison and Judy, can you share a little bit about that and kind of respond to those questions or comments about when the data may not fit in individuals' personal health care requirements, and also about supplements and data on that, if there's anything at the conference?
Oh, go ahead, Judy. I see you.
No, you can go ahead.
No, I mean, I think I can't underscore not the importance of shared decision making. I think, certainly no matter how good we do with trials and recruiting people, there is always something, right? There is not representative these people or that people. I think we've gotten better where we have better representation of diverse populations, but it's not always perfect. And as you all are pointing out in the chart, in the chat, that I don't see myself here. And so can you just extrapolate this to me? And I think this is where it absolutely is important to not just receive, but to engage. And if your provider is just having you receive information, then you have the wrong provider. It should be an engagement. It shouldn't be, this is the only thing that you can do. And I think Nina is very vocal about, this is suggested, but I don't think this applies. And that is okay. I think actually it is about choice, and it may not be the right choice for you with all of these things that we're talking about. In terms of the question of vitamin D supplementation, I have brown skin, and we certainly know vitamin D deficiency is more common in those who have more melanin. And so I do see a fair amount of vitamin D deficiency in Baltimore, where I practice. And from the young to the very old, I take care of the whole spectrum. And I think, again, this is one, it is hard to take. It's once a week. It's hard to remember. But I do feel, and there are studies to say that vitamin D can impact all kinds of things, from metabolism to fatigue to what have you. And there are times where you take it to the personal, where people feel better when they do get supplementation. I think not doing it for longer than you need to, or making sure that you're, again, sharing decision making and following up is important. I didn't see a lot on vitamin D at this conference here today, but it's certainly at past conferences, there's been lots on vitamin D. And certainly depending on, again, what's happening with your bones, what's happening with lots of things, I think important to have those conversations with your provider.
Thanks.
Yeah, I don't have a lot to add to that. I think it's hard to make a general proclamation about the importance of it. Despite the fact that we've seen low vitamin D and it's been associated with lots of different things, really studies have had a hard time showing, other than for low bone density, that giving it changes that outcome. But I think it is an individual thing. And so I think it has to be made sort of a one-on-one with your provider.
Thanks, Judy. So why don't we look at Andrew's question kind of about what is happening now as people are aging into their 50s and into their 60s. People are retiring, maybe moving around in their local countries. What should we be advocating for in terms of services and support systems in more rural care facilities? So any thoughts about that? I know that you're speaking from the US perspective, and it may be a little bit different from Malaysia, where Andrew is, but any thoughts about that?
Yeah, I mean, I think it's really hard about just the fractured healthcare systems we have globally, and in many places for for people living with HIV, the focus is just on the HIV medication and the delivery of that medication and not all the other services and things that are needed. So it's a very challenging issue. And I think that as people age and migrate, I think it is something that we're not prepared for in terms of how to manage some of these issues. So I think it's a big issue that needs more attention.
Yeah,
I'd love to add to, oh, sorry. I mean, I think, certainly the context matters. And I think, particularly we have fractured healthcare system, but also depending on where you are, the sort of the structures of families where people are available to actually support people as they age don't exist for some places, and isolation is a huge thing. And so I think, a lot of the services that I think Andrew alluded to that are needed to support people beyond medications may be covered by Ryan White, case management and things like that. And that funding is being threatened. So I think are there things to do? It's to advocate for funding and to be expansive in what that funding can do to support people as they go on to live and to try to optimize their aging with HIV. So a really important question and an opportunity for advocacy.
Thanks, Allison. And maybe we can start talking a little more about the injectables. There's been a lot of comments in the chat from people who are on them, as well as people who are thinking about them, and potentially others of you in the group now who frankly don't have access to them because these drugs are not yet approved for importation in your country, especially in low and middle income country settings. But any updates on some of the data? You mentioned the CARES study, Judy, that Nick presented yesterday. Nick is from Singapore, and so maybe you could share a little bit more about where you think the field is going. And people have asked about, well, what about stretching that out to more months? Or what about a once weekly pill? I mean, where are we with these kinds of innovations for treatment?
Yeah, I mean, I think there was a question in the chat about, once a week pill, is that going to be a game changer or not? And I think it goes back to this issue about having choice. I think for some people, taking a pill once a week rather than once a day could be something that was found to be, an advantage, but for others, not so much. You forget, you might forget. And so, I think this is an area where one size doesn't fit all. And our currently available injectables are not available everywhere, as you highlighted, but the cabotegravir-rilpivirine combination, it does have limitations. You can't use it if you have hepatitis B or you've had, previous significant resistance to NNRTIs. But if you've been suppressed on a regimen without that, you can switch. And we're going to hear more later this week about people who've had challenges to adherence in the past, but are able to become suppressed on an oral regimen, being able to utilize and benefit from this. But that's not till Wednesday, so I can't really talk about that yet. But I do think it is, sort of intermittent dosing of treatment, whether it be injected or oral. There's a lot of work in developing it, and but I think what we're learning is that we have to figure out the access in parallel with the development, because with cabotegravir and rilpivirine, which has been approved in the US, we still don't have the infrastructure in many of our clinic locations to actually operationalize this. And for some people, who take a daily pill and are doing well and come to the clinic every 6 months, well, now they have to come every 2 months and get a shot, and they have to make sure they get it scheduled. And, so the infrastructure for managing that in really busy clinics was not really developed in parallel with the development of the products. And I think that's an area where I do see more focus on, funding studies to look at implementation and how to set these things up, and really need to be done in parallel with the development of the products.
No, I don't have much to add. I think the access piece and thinking access at the time you are actually designing the studies is super important, and not just access as the team thinks about it, but the country, the layers that are going to be involved to actually do it. I think that the comments about it's not for me, I think that's important. but it's for someone. And I think it's all, again, it's about creating the a la carte of options. And it may not be for someone at one time, but it's for them for another time. It may be for while I'm traveling, doing the Peace Corps for a year. But I think I'm so excited about seeing what's next, oral long acting, patches. I think that's where we need to be. So you literally can be at a menu and decide what works for you. But we have to work out the access issues, or we're going to continue to see disparities, growing disparities with who gets these and who doesn't, which is it's unacceptable.
Thanks, Ellison. And you use the word choice, and that's
Mhm.
such an important thing. I think people have talked a lot about options for prevention, but what about options for treatment? Especially in global guidelines, everybody's supposed to be on TLD now. Well, is that it? What about people who have serious insomnia with that regimen? What about people with TB? All of these studies that are coming out now. What about kids? And so that kind of brings me to the comment that Judy shared about sleep. And so there were a lot of responses from people who are like, sleep is so important. So any other comments about that? And also linking it to COVID and potentially that overlay between long COVID symptoms, side effects from medications, HIV. Other thoughts about that, Judy?
Yeah, I did see a question in the chat about this long COVID session yesterday, and I regret I wasn't able to be there for the last two talks about suggesting potentially whether the risk of long COVID was higher for people living with HIV. There may be others on the call here who can comment on that were in that session. And, long COVID is a really serious issue that we're grappling with, how to make the diagnosis, what are the options for treatment, if any, and the very different manifestations of long COVID. It's not everybody who suffers from long COVID has the same symptoms. They can be more neurologically focused. They can be more fatigue and post-exertional malaise focused. They can, they can be more sort of having dizziness and other sort of symptoms when you move around. So it seems like it impacts people in many different ways. So finding one treatment that is going to be effective, I think, is really a big challenge. But there are studies that are going on now, finally, and I think that we're going to be learning a lot more. And so I'd like to, if somebody was at that talk and wants to say what it found, that would be great to share that here.
Thanks, Judy. And I see Jim has raised his hand. So Jim, do you want to comment about this too, or something else?
I mean, there's so many things I want to comment on. You all are having just the best conversation, and the chat is on fire again, like yesterday. Oh my God, there's just so much to take in. Just a couple of things. I'm really glad we're talking about choices. As someone who's been living with HIV since '95, I get a little concerned when everything is injectable. Everything is like injectable or implants or something. I think a weekly pill may not be for everyone. I think it could be for me. And I just appreciate, like, let's not get just in that injectable kind of framework, because whether it's available or not doesn't mean that it's accessible. And even if it's, it's in your neighborhood, who can come to the clinic 12 times a year or 6 times a year? Living with HIV as long as I've had, twice a year in my clinic is enough. I like my doctor and I like the staff who work there, but I don't want to see them any more than that. I don't want to make my healthcare my full-time job. And so we need things that can be controlled by the individual. And all these things that have to be delivered in the clinic are kind of problematic. So I'm also interested in what you all are thinking about in terms of task shifting. So, like Rupa Patel at Whitman Walker, who was at Whitman Walker in DC, did this amazing PrEP and injectable treatment clinic where they trained a bunch of staff who weren't clinicians to give shots, just to improve access and time frames for appointments. So I'm wondering, how much further can we push that? I mean, can we have injectable for treatment that can be delivered by your partner? By the nice neighbor lady who will happy to give you a shot in your butt every month. Can we move task shifting outside of the clinic into the home, so I don't have to ever leave other than to see my doctor once or twice a year?
I'd love
What do
to
you think?
Yeah, no. I mean, I think I just responded to Victor raised the same point in the chat. And I think there is a move to do some of this. I know in our state, our pharmacists actually petitioned the board so the pharmacists can actually give the injectables. So you don't have to actually have your provider do it. Because honestly, if you're going to have your provider do it, one, we don't give shots usually. And so you don't want us giving the shot, right? So it's a nurse or there's some sort of process. But if it can be given in the community someplace close to you, particularly when we are living, many of us in areas where there are deserts, where there are no ID docs or clinics and people having to travel for so far to go to their clinics. So can you imagine you having to do that on a regular basis to get the shot? It would not be feasible or sustainable. So your points are well raised. So how do we task shift so someone else can give the shot, whether it's my pharmacist? Could we get to me giving my shot at home? We do this fertility treatment. So can we do that in other ways? And I think this is what needs to continue to be pushed. Does it need to be done this way? Asking those questions and pushing the envelope.
Thanks, Allison. And I think Mitch put it in the chat and kind of addressing this. There's a difference between developing biomedical options and delivering feasible choices. And that's not just here in the US, but also around the world, as has been mentioned. So Jeff, you have your hand raised. Go ahead.
Yeah, thank you. So there's been a lot of talk about kind of the behavioral things we can do. And certainly in the setting of controlled HIV, other than having all these comorbidities happening earlier, we're not that much different from the general population. And there's a huge body of research out there, but it needs to be validated in HIV. And this often requires really big studies. We did it with Reprieve. And I'm wondering, where is the political will to make these studies happen so we can get the data we need? Because, prescribers can't write prescriptions. They can't. Policymakers can't fund, use Ryan White monies for gym memberships, things like that, unless we've got that evidence to support those choices. So, how do we do that? And to our international colleagues, have you managed to get over this hump? And Judy and I have had long conversations over this over the last few years, and it's structurally, we're not designed to do this in our current HIV research, network. So, how do we get over that and get people what they need and get providers what they need?
Yeah, I mean, I think we have to prioritize, because I don't think we can study every single, chronic disease in a 7,000 participant study to demonstrate the benefit or the need. In the case of Reprieve, we found that the need or the indication or the benefits for statins occur in people younger with HIV than had been previously if you just went by the regular guidelines. So I think for most things, we should be doing the things that have been shown to be associated with healthy aging without having to wait until we have a study that shows it's beneficial. And for that exercise, I cannot emphasize how clear the benefits of regular exercise are for mental health, for healthy, for just longevity in general. And we don't have to wait until there's a study. And there are studies in people living with HIV showing the benefits of exercise to say that this is something that people should be doing. Now, what's the optimal type of exercise, and how do you implement that? How do you get that into people's lives? What are the ways that make that possible? I think those are things that, that can be studied through implementation. But I do want to be careful that people aren't waiting for us to study everything, in giant studies before they think about, before they think about incorporating into their life.
Yeah, I think people know it, but in terms of, allocating resources, they demand that evidence base. That's what the challenge is for those of us who are doing policy advocacy.
Thank you. Thanks, Jeff. And Isulu, you have your hand up.
Hi, everyone. And I think, something really interesting that was brought up yesterday during the luminary session for community educators was the fact that what we do when we have access to these innovative medications as a participant of clinical trial, but then because we live in a low or middle income countries, when the clinical trial is over, we don't have access to this medication, and we have to wait until it becomes generic or until, the brand company signs an agreement with the generic company, and it takes sometimes ages. So we have to be very smart about, every time if we have a possibility to attend and review clinical protocols, make sure that we are demanding for access to this treatment for everyone who attended the treatment, so that they don't have to switch back to something less maybe effective or less wanted once they had access already to something new that worked for them. And something that also struck me during the whole CROI presentations is that how little data we have related to women. Most of the clinical trials are usually male participants. And even when it comes to animal species, you know, you see that most of the species were male, not female. So we don't even have a hint what could go wrong from the animal studies that could actually help us to maybe be, take some precautions, or vice versa, be more open to suggest that this actually could be a drug for a pregnant woman as well.
Thank you, Isulu. I know Allison and Judy are both big advocates for more research data and care specific for women. Do either of you want to comment?
Yeah, I mean, I think it's a really important point. I would highlight the CARE study that was done looking at long-acting cabotegravir and rilpivirine had over 50% women enrolled. And that was in sharp contrast to some of the early phase studies that were really small with 10 or 11 people, where there were maybe 2 or 3 women, where it makes you sort of cringe when you see that. And but the studies as the drugs are moving, across development, we're doing better. We can always do better, but I was really pleased to see that in the CARE study, that it was really representative of the population living with HIV in those settings.
Well, I saw your point is well taken, and I think that's the first thing I tend to look for is sex, and then look for demographics and is it racially representative and all of that. I think with the attempts to do it now with all your grants that you write, you're supposed to write if you are not including certain groups, why you are not, and justify why you are or not. I think we have to keep pushing that and justifying. Should you actually. You want to get a population enrolled, and that's great, and get our studies done. But if there's a need to make sure that we have 10, 20, 30, 40, 50% women, then we have to state that and to push for that. So your point, again, well taken. We have to keep pushing, because we're way ahead than where we were years ago, right? We used to sit in and it was conference abstract after abstract, where it was all males, all white males of 40 years of age or older, median age, and what have you. And I think that is changing, but it's because of advocacy and pushing for it to change. And so continue to highlight that.
And I think we should now, to bring this fight back to the preclinical trials as well, make sure that animal species as well, we have sex ratio. Because, okay, I can get all your ethical, arguments why you are not wanting to involve women, but when it comes to the animals, come on.
That's a good way, Isulu. When it comes to the animals, come on. I think that's a good point. I also want, before we move to the next point, emphasize also that transgender women are routinely excluded from these types of trials. And then when we have data, we still get data and analyses, like at the Journal of the International AIDS Society, sorry for the plug, but where MSM and transgender women are combined repeatedly, and we have to tell the authors to disaggregate those data. This should not be something that researchers don't know about at this point. And this includes involvement in clinical trials. And so I want,
Can I just add, I think we oftentimes talk about trans women, but we don't frequently talk about trans men. And I think that is also an important population. And then the spectrum, right? And the argument would be, well, you can't have a bucket for everybody, right? But I think we have to be inclusive as often, as much as we can. So just wanted to make sure I mentioned that.
Thank you.
Yeah, and I think that we also have to be careful. I think that we need better representation. I don't know that necessarily, if the study doesn't show a specific group, that they were excluded, but they weren't enrolled. And so I think we need to make a differentiation between actual exclusion and lack of inclusion, because they are two different things, and we need to figure out ways to make the studies more inclusive. Because I think that I'm not seeing studies specifically exclude trans men or women, but to make sure they're identified when they're enrolled, and to increase efforts to be more inclusive.
I think that part, Judy, is also key, because oftentimes we say, oh, they're hard to reach, so that's why we don't enroll them. But I often flip it, or they're hardly reached, right? So how do we make sure we include, because they're not included necessarily, excluded, but if we're not making efforts to make sure they know they're included, they may not be included. So I think just, emphasizing.
Thank you. There's a comment a little early on in the chat from Kennedy that I thought was something that we can think about as we sort of move toward the end of our hour. Shocking. It's already been like 50 minutes. And Kennedy said, we have no global consensus or guidelines in the management of HIV and aging. Our healthcare system and policies in Africa are not providing for HIV and aging support programs. What can we do as aging activists to push this agenda into the global agenda? And I would say here, when we define aging, we're talking about living 30 years with HIV, 20, 30, 40 years with HIV, however it was acquired. So any thoughts about that? And actually, we're not the best people to answer the question about how do we advocate. I think you are in this room, so would really encourage you to respond to Kennedy in the chat too. But any thoughts about that? And then I can also comment. Allison or Judy?
Yeah, I think it is really the integration of primary care into HIV care in all these settings around the world, and how and how that's, and it may be country specific, it may be program specific, but just making sure that primary health care is a part of HIV care, and then thinking about what are the priorities for these needs. Diagnosis and management of hypertension is really an important thing for long-term health. We're going to hear more about that today in the complications session, some of the interventions that are being done to integrate hypertensive care into HIV care. So I guess in terms of advice for advocacy, I would try to focus on where the priorities are for the things that need to be incorporated, to just be as specific as possible.
Saying that if you did it, I apologize, I didn't see it. But has there been an IAS issue focused on aging, not young, but at the older age?
Yeah, actually, one of the guest editors for that supplement was here. Let me see if Rena is still in the chat from Malaysia. Yeah, hi, Rena. So there are, and Rena, if you are available to put into the link the issue, the supplement issue, but it was mentioned that maybe IAS is a better place to talk about some of this kind of advocacy. But perhaps I would say, Jeff, more in the context of it being more of a global meeting, and CROI not necessarily identifying itself as a conference as a place for advocacy, but I want to highlight that a lot of the people who are speaking at this conference presenting their work are invited to sit on WHO guideline development groups and committees. So to one of today's plenary speakers, Charlie Flexner, he is advising the WHO, the Clinton Foundation, UNITAID on long-acting extended delivery medicines. And so I think the people who are at this conference are still potentially those who need to hear these sorts of advocacy messages. And the Martin Delaney talk was incredible. And I just saw a lot of scientists from basic clinical epi just wowed and really amazed and so shocked, some of them, about some of the information that they had never heard before, and CROI would be the only place that they might hear it. So any other thoughts from the group? Anyone want to raise your hand about that? Other comments about that? So, well, like there's so many chat comments. I'm like, my eyes are like crossing because there's a lot of information there. But a theme perhaps that is coming up is about inclusion of different people in research studies, and the difference between equity and equality, like the numbers of participants versus who are there and where they are in terms of location as well, geographic location, country income level location, things like that. I think that's something that we should keep our eye on. And a few people have pointed out, like, look at the author list, people. And I think sometimes that's not something people emphasize very much. They look at the data, but for us to be in a time when, for example, you're doing an analysis that includes transgender people or highlights issues of transgender people, and you have no transgender people on your authorship list, or there aren't advisors involved, I think I would hope that we are beyond that. So as far as other clinical questions, maybe we can have a final comment, actually at this point now, because I just looked, I'm like, whoa, we only have 3 minutes. So maybe a final comment because Allison, you went first. How about Judy? You go first on the final comment, and then Allison, and then Jim is going to close us.
Yeah, I would just thank everybody for the great comments and input today, and just encourage everyone to continue attending these sessions and make a list of the ones you didn't get to listen to, and listen to them when you go for your morning exercise walk over the next few weeks. There's just so much data here. We all need time to process it and figure out what it means, but it's so great to have all this this discussion.
Yeah, no, echoing Judy, thanks for inviting me to talk. It has been great talking with you all. The chat has been on fire. I think all I would say, in addition to Judy's, is it's not just attend, but don't be afraid to go up. Not that this group is afraid. Go up and challenge. Ask the questions, challenge, because sometimes, honestly, it's just not been thought about, right? And so you may spark someone to do something or think about something differently. So ask the questions why and why not, and push. It's really from integrating with the voices of the people with the lived experience, which is you all, that actually the questions come out. And oftentimes you all are the canary in the coal mines that spark the research or say, how does it get back to us, right? So really think these are the sessions that have to happen. I can't believe it's the first time I've actually experienced a margarita breakfast, whatever. But I think really important and a critical part of how we then interpret and move what we do forward. So thank you for involving us in this conversation.
Jim, over to you.
Okay, well, first of all, let's everyone give some love in the chat or with reactions to this amazing panel. Judith and Allison and Annette. I love these roundtable discussions. They're so rich and it's hard to keep up. So we will, when we share the recording, we will also capture everything in the chat and put it in a document so people can go back and pour through there and see the questions and find resources for yourself. So we'll include that because I know for me, I've not been able to keep up. And this is kind of what I do, and I can't keep up. So thank you for making it hard to keep up. Thank you to everyone who has been so active in this chat. You're right, Allison, we have to challenge, and I think you got the right people in this room who are born to challenge and are wired to challenge, and I encourage everyone to continue to do that in every single room and every single venue you are. That is how change happens. Sometimes people are just not aware, and sometimes people are aware and they need to be pushed, and they need to be pushed, and they need to be pushed. And nothing for us without us. And I'll end with, you know, the old ACT UP phrase that is as true as it was in 1988 as it is today: silence equals death. So if there's an issue, if there's a problem, do not stay quiet, raise your voice. People living with HIV, like me and many in this room, are experts on our lives. And no one can take that expertise away from us. No one has the expertise on me better than I do. So I have a responsibility to really share that in every way I can. And even if it makes me annoying or obnoxious, which it does all the time. So with that said, it is now the top of the hour. The next, the CROI opening plenary for this morning starts in a half hour. So as I said yesterday, get on your roller skates, head over there. Tomorrow morning, we'll be back here at the same time, same place. We have a panel of 4 folks, 2 researchers and 2 advocates, who will be breaking down all the things they found fascinating at this conference. So you can bet it's going to be a crazy, wild ride for another 60 minutes. So I hope you're all there. And with that, we're going to close out and send you on your merry way. Thank you so much.